Hello, and thanks for joining us as we discuss the internal cost savings gain sharing agreements, specifically from the standpoint of Coastal Orthopedics, which will give us some really good insight on how they've established this relationship with their hospital and got this movement through their BPCI Advanced program. For introductions, I'm Ralph Festa, Senior Director, Client Solutions and Engagement for Fusion 5. I cover the East region for Fusion 5, and one of those groups is Coastal Orthopedics. Dr. Arthur Valadie, Physician President, is joining me, and I'm pleased to have him join us to discuss this program.
Hi, Ralph. Happy to be here and to talk about our experience with the ICS component of the BPCI Gainsharing program.
As far as the agenda, here's a little roadmap of where we're headed with our discussion. The real intent for this webinar is just to give everyone a step-by-step outline on how episode initiators can set up these arrangements and really take their BPCI Advanced program to the next level. We'll go through all of these topics from the standpoint of Coastal, and hopefully you'll come away with some good tactics and methods to get this started from your program. So Dr. Valadie, I'll pitch it to you for a description of your practice. Let us know a little bit about where you are in BPCI, where you've come from, and some of the arrangements that you have in place.
Sure. So we're an independent physician-owned group in Bradenton, Florida, on the west coast of Florida. We've been around for a long time. We've been in BPCI since the beginning of the program. I don't know if I said how big we are. We're 20 physicians. We have some pain management and some non-surgical physicians, primarily a surgical practice though. So we started out in the original BPCI program in 2015, and we started our initial ICS program during the BPCI Classic program. And then in the BPCI Advanced program with Fusion 5, we have an ICS program with one of our hospitals, our HCA hospital. Our surgeons are participating. Obviously, our non-surgical providers are not. And just again, by way of context, I have about 5 surgeons that do a fair amount of inpatient work. But then I have other surgeons, such as hand surgeons, the foot and ankle surgeons that do fractures, who also take care of BPCI patients that fall into this program. We have one HCA hospital, and that's the one that we currently have the program in place for the BPCI Advanced program. And then we have 2 Universal Health Systems hospitals that we participated with successfully in the initial BPCI program, but they just have some organizational inertia that have prevented us from getting the program going during the BPCI Advanced program. So currently with Fusion 5, we're doing the lower extremity episodes. We actually dropped the upper extremity episodes when they came out with the new target prices in 2020. They dropped the shoulder so low that we stopped participating in those as an episode. And then we picked up hip fracture, spine fusions, and some of the lower extremity and humerus procedures.
So a quick overview of the internal cost savings program, just the definition of it, and give a little bit of context behind that. The internal cost savings arrangement, obviously it's a way for hospitals to gain share with surgeons for specific cost savings measures through the BPCI Advanced program. Given the situation now with the COVID-19 pandemic and everything around that, we've seen some real willingness from hospitals to look for other avenues of revenue, and a real willingness to partner with physicians and their practices to drive some of these cost savings measures. So we've seen the increased opportunity where this could lie. So that's where this initiative is coming from. Really how this is achieved, analyzing that historical baseline cost for agreed upon expenses for all cases. Really anything that has a variable cost or using a vendor, anything that has a baseline cost, something that we can adjust or negotiate, is really in scope for cost savings measures. Dr. Valadie, is there anything else other than these 4 options that might be beneficial into the implants, bone cement, blood utilization, but anything else that you've seen that really could be a cost savings measure?
Really, at the end of the day, the big money in orthopedics is in the implants. Bone cement can be a few $100s a case. You can make a few dollars there. Blood utilization's gone down so much with the use of tranexamic acid that that's really not significant anymore. I would have liked to look at length of stay, but hospitals had a tough time quantifying the cost for that. How do you deal with variable and fixed cost components? So there's a lot of things you can look at, supplies on the back table in the OR, but at the end of the day, where we are currently, implant costs for joints and spine and fractures is really where the money is.
Okay. Well, once you've analyzed these baseline costs and you've kind of looked at what makes sense and what doesn't, assessing those costs for BPCI advanced episodes specifically to see how much money can be saved with those patients and what the real opportunity may look like. Some methodology that's been used to divide the savings and distribute, only using the BPCI advanced episodes and letting the hospital get all the savings for non-BPCI cases. Dr. Valadie, is that a way for the hospital to really get more return on investment or make it a little bit more lucrative to them to keep all the savings from non-BPCI cases as well?
Yeah, well, the nice thing about the program is you have some flexibility, right? So you have flexibility in terms of what cost you agree upon, but again, joints and implants are really where the money is. You also have flexibility on how you do the agreement with a hospital. And so regardless of how you split your BPCI savings, they're going to get all the money on the non-BPCI commercial patients and Medicare Advantage patients. And so, their win or their hope is that whatever measures you put in place for your BPCI patients, you also, that those carry over into the non-BPCI patients where they get all the savings. So certainly that's a nice win for them based on the payer mix, and again, based on the physician's willingness to spread those cost savings initiatives beyond just the Medicare patients.
So the discovery phase, as we're, this is the most popular question I get when I talk with groups about this arrangement. Where do we start? Who do we talk to? What questions do I ask? How does this get rolling? We call this the discovery phase. And Dr. Valadie, can you maybe walk us through the discovery phase and where you started and who those important people at the hospital may be to engage with first?
Really, at the end of the day, this is a relationship issue. And so it really depends on your relationship with the local hospital and who those relationships are with. So in our specific example, as a physician leader of my group, I maintain a relationship and regular communications with the CEOs of all three of our hospitals. And so really this was, in our case, it was an example of me going to our hospital leadership and saying, hey, here's this program that is legal and safe and conservative that's going to allow us to collaborate. And not only can we put some money in your pockets, but we can also work on a collaboration between our surgeons and the hospital and get everyone thinking about the cost of what we do. And at the time we started this was just really novel, right? And so our surgeons typically really just didn't pay attention or know anything about the costs, the internal costs of what we do, implant costs, were just something that really weren't of concern to us. And so this is a way to get physicians thinking about that in addition to making some money for the group and for the hospital.
So I know this wasn't a real issue on your end, but if you would get any pushback from a hospital or leadership at a hospital that they just really weren't willing to do this or didn't want to talk to you about it, any tactics to kind of drive the fact that this is a good program, this benefits both parties? Just any thoughts on that?
Really, again, it's a relationship and persuasion issue, and you really need to have both parties willing and engaged to do it. So, for example, UHS, we haven't been able to push through this program with BPCI Advanced largely because of their inertia. So if they're busy with other things or not interested, it's simply not going to happen. So I think it's a relationship and persuasion issue, and you have to be able to convince them that not only are there dollars involved, but there may be some long-standing behavior change regarding paying attention to the cost of what we do that could benefit them in the long run. And I think most hospital administrators are willing to listen to that, and I think that kind of conversation gets their attention most of the time.
Great, that's great insight. Thank you. So engaging a third party, Fusion 5 potentially, to manage and provide oversight to the program. Obviously, we're going to be involved in setting up the agreement. Once there is agreement from the hospital to put together these measures, save some costs on the procedures. We can be there to set up the agreement, put the contract in place. Outline your quality measures. Everything needs to be tied to quality as usual with these value-based care programs. And I think one of the most important things is to add another set of eyes to protect the best interest of the practice. A lot of fine print, contractual issues. We want to make sure that this is in the best interest of the practice, and you're going to get maximize the opportunity for you. Dr. Valadie, maybe you could elaborate on the ICS committee at each hospital. I think this is a little bit new. I personally didn't know that this was a portion of your ICS arrangement or kind of the operations piece of it. Could you maybe elaborate on that a little bit for us?
So you need to have a committee that is going to obviously set up the agreement. So choose the quality measures and choose the design of the program. And that committee, in our case, I think we have 3 physicians from the practice. And I think there's 3 representatives from the hospital. And typically that's a CEO of the hospital, maybe a finance guy from the hospital, guy or lady from the hospital, and maybe an operations person. So I believe we had 3 people on each side. And then those committee meetings were moderated by the third party that you choose. And you really do need a third party to set it up. The setup of the agreements is fairly complex. The analysis of the data is fairly complex. So we found that to be invaluable. And then that committee would get together. We typically did, sometimes we did it in person, sometimes we did it by phone. But typically we would gather the data on the performance period that we wanted to review. We'd send it out, everybody take a look at it. We'd have a fairly brief meeting to review the results and look for further opportunities, maybe take cases that were outliers and take a look at those. And then the committee would approve the results or ask for any clarification, and then that could be signed off on and processed.
So as we move out of the discovery phase and into the opportunity and rollout phase, so you have a hospital partner that's interested. Now where do we go? Fusion 5 in the hospital can calculate the baseline costs. Dr. Valadie, maybe walk us through that process. The work with your vendors, how you're picking out the cost savings measures, and how that gets established.
Yeah, so really the first thing to do is just look at your baseline costs, right? So you have to pull the data on what your baseline costs are for whatever costs you choose. So let's take implants, for example. So you would take all of your total knee replacements that were done over a period of time, and then you would go back, Fusion 5 in the hospital would go back and pull that data, and you take a look at it. You see that your experience is you're paying $5,000 or $6,000 for a knee replacement. There's an opportunity there to drive that cost down of that implant. Now, if you go and look at it and you see that you've done a great job in the past and you're getting those knee replacements for $2,500 or $3,000, there's probably not much opportunity there. It's fairly similar to the baseline costs on the NIPRA portion of BPCI. So really you have to go back and look at the baseline costs, and then looking at that, see whether you think there's an opportunity to lower those. And then once you see that opportunity, then you have to get with your surgeons and obviously explain the program to them, let them know what the opportunity looks like, project out it over a year, and then you can initiate some behavior change around that. Yeah, in terms of getting with the vendors, that's really the hospital and the physicians will work together to talk about what implant options there might be, what other generations of implants, can you do some demand matching, say for lower demand patients. So there's a lot of ways you can work with the vendors to drive that cost down.
Great. So, we pulled baseline costs, we've talked to the vendors, there's opportunity. So where do we go now? We get the committee together, we talk about what we'd like to do, here's the financials, here's the potential. How does that get rolled downstream from the committee to all the surgeons to the practice? Where do we go from there?
In our case, that's, and I think most cases, that's really a physician leadership, cohesion, and communication question. So once we identified an opportunity, then we went to the surgeons that could affect change, again, the ones that are choosing implants, and we would look at what historical costs are, and then we would talk about what the options are. So one of our most productive total joint surgeons, for example, saw the cost of the implants he was using, and he worked with another vendor that had a lower cost implant, and when appropriate clinically, he would choose that implant and really effectively cut his implant cost in half. And he was comfortable with the quality of the implant, comfortable with the outcomes he was getting. And so he made a pretty significant change in a fair bulk of his population on the lower demand patients and saved a lot of money there. So really, you start pressuring vendors or changing vendors, and that's when you start to see change in their pricing or what they're offering. And again, so you have to discuss that with all of your surgeons. In our case, I also had other surgeons like hand surgeons and foot and ankle surgeons took call, so they needed to understand that why am I using a $4,000 press fit implant for a hip hemiarthroplasty in a 95-year-old patient when I can use a much lower cost implant? And just seeing the data is eye-opening. I think a lot of the surgeons just simply had no idea that they were using these high-end implants in these very low-demand patients. And I think when they see that information and data, they're often willing to make a change, particularly when there's a potential reward for them.
In the recurring meetings, that you're going to have at the hospital, I think this was a key point just for the collaboration. Yourself, your administration, and the hospital all getting together regularly to review the results. Is the main goal for that just to make sure that the protocols are being followed, the right vendors are being used, and try to track the data and make sure everyone's transparent with everything?
Well, I think first of all, you're reviewing the data to make sure that you're engaging in an activity that is resulting in some benefit. So you want to make sure that you're doing well. Secondly, there are cases that are going to be outliers. So we would, for example, you'd find a high cost case that was way out of what it should be. That would give you the opportunity to go back and look at that case, and often that case should not have been included. So for example, a very expensive revision implant got counted into the episode when it shouldn't have. So I think I identified ones that needed to be dropped. So it's sort of a double check on the system. Thirdly, I think it gives you a nice summary of where you are. So what I found effective in our practice is after our meetings, I would basically summarize the results in a brief paragraph in an email to all of our doctors. It was either a quarterly or semi-annual update, and say, at this hospital, here's how many cases we did, here were our baseline costs, here's what we drove the cost down to, here's our net savings, here's what the hospital got, and here's what we got. And basically saying, hey, this program is beneficial, it's worth spending your time and energy on, let's continue to do it, keep it front of mind. So those were the sort of the three things that we found beneficial in having these regular meetings. Not to mention getting the physicians and the physician leadership in the same room with hospital leadership. There's nothing wrong with growing and developing those relationships.
Oh yeah, invaluable, absolutely. So as far as the savings distribution, just really give us an example of how this is set up at your practice, from the classic program into the advanced program, just to give some folks an idea of how this is set up. I know these are typically negotiable, but give us the outline of how this is split up with you and your team.
Yeah, they're pretty flexible. The way we had it in the original program was pretty beneficial to the practice. So for the eligible episodes, we would take the first $700 per case in savings. And I believe it was done in the aggregate, as I recall. We take the first $700 in savings, and that would go to the group. Now, in the original program, I don't want to get too much in the weeds, but each surgeon was capped in terms of their benefit from the BPCI program, both through NIPR and ICS, at 50% of the professional fees. And so if a surgeon drove ICS savings, that would go to them up to that cap of $700, and then the rest would go to the group. Now that would diminish the amount of NIPRA savings that they could get because of the cap, but it didn't really matter. That money basically was a benefit to the group. In the advanced program, it was set up a little bit differently, and I think the hospital wanted the physician group to take the risk for paying the third party. And so the way it's set up in BPCI Advanced is that the savings are split 80-20. So the hospital gets 20% of the savings on the BPCI eligible patients. And again, they get all of the savings on the non-BPCI patients. And then the other 80% comes to the group, but the third party administration fee comes out of that before any dollars flow to the group or the surgeons.
And the third party admin fee coming out of the 80%, that's specific to the negotiation that you have with your hospital. That's why it's different from the classic program, right? That's just the hospital preference or how it was negotiated.
That's exactly right. In the original program, the hospital paid all of the fees, and in the new program, I think that they wanted us to take the risk for that to help drive, behavior change. And if there weren't any savings, they wouldn't be on the hook for it. So that was just a negotiation with HCA.
Key results and takeaways. So, I know that we've talked with a lot of groups about, implants get you the biggest bang for your buck. But, what did you see as far as the biggest bang? What kind of success did you see in the program, or have you been seeing in the program?
Well, the primary savings were in implant costs. Now, in the original program, we did not include fracture episodes, and so there was a nice benefit on the implant side, but because the pricing resets over time, then it's a time limited opportunity. So when we added fracture episodes, no one had ever paid attention to those implant costs, just like we had with joint implant costs before. So the opportunity may change and evolve over time. On this slideshow, there's little things like upcharges and polyethylene choice that we put in there, simply because I think it's eye-opening when you start to the program, you start to look at invoices. So you may have a baseline implant cost, say of, just pick a number, $4,000. When you actually look at the implants, you'll see that they upcharge $500 to go to a cross-linked polyethylene, or they upcharge for some other type, like a stemmed implant of some kind that may or may not be clinically significant. So my point being is that it's important to look at the actual costs and the actual invoices, and that's really an eye-opening exercise.
So when you say that you've seen less significant savings with the non-BPCI cases, is that attributed to those patients being a little bit more high level? They need a little bit better than your generic implant. They need a little bit more high-end tool?
Yeah, I think there's two reasons for that, frankly. I think number one is if you're doing some demand matching, meaning that you're going to use a little higher end implant on a younger patient, that patient is likely to be commercially insured. So there's a lower likelihood that they're going to get the lower cost, low demand implant. And then there is some physician behavior in this as well, right? The physicians are going to know which cases are going to drive reward to them. So there's going to be some difference in behavior between the BPCI eligible patients and the ones that are not. But you still see overflow, right? You still see once physicians start paying attention to cost, there's going to be some benefit across the board on all your cases.
So what everyone's probably wondering, show me the money, the financials. What's really in scope for potential savings, potential gain share? How much revenue can you actually make through this? So maybe walk us through the savings that Coastal generated through the program, and where that might cap out at.
Yeah, so again, it depends on a couple of things. I would say the two biggest factors are what are your baseline costs, and then what's your degree of physician engagement and their willingness to change. Those are really the two key factors. And these aren't huge dollars, but in today's day and age, every dollar helps. And so this is basically about 2/4 of BPCI Classic. Since one hospital the HCA hospital was unwilling to share their non-BPCI data, we really couldn't get a full picture of what the program was accomplishing. So this is the data from the two UHS hospitals, which interestingly, again, we don't have a current agreement with. But the net cost savings over those roughly 2 years was a little bit north of $500,000, so not too bad. About $213,000 came to the surgeons over a 2-year period, so a little bit over $100,000 a year. You can see that the admin fees in this agreement were paid by the hospital. But the hospital had a net upside of a little less than $100,000 a year, and not bad. And probably more valuable than that was spending time with surgeons discussing the cost of what we do. So that's just a snapshot of two of our hospitals over a roughly 2-year period.
Mm-hmm. The one that stands out to me so much here is the collaboration with the surgeons and the hospital, that being priceless. This can open up so many more doors in the BPCI Advanced program, just the partnership, the collaboration. I've seen a number of different groups that don't have the greatest relationship with their hospital, following their protocols, their pathways. When the hospital is seeing some financials from this, sharing in some of the savings, like I said, that can open up a lot more doors, a lot more avenues for your clinical episodes in the BPCI Advanced program. So increasing that partnership is just that priceless.
I've not seen a situation where an adversarial relationship with a hospital is beneficial. I think they're common, but I've never seen one where they're beneficial. Whereas I think some degree of a cooperative experience is certainly not going to hurt, and it's likely to help in some way, shape, or form. And it could be in this program. It could be in them getting their case managers to help you on the NIPR side of the equation. It could be on them saying, hey, we're not going to bring in a competing group because this group wants to work with us. So I think there's lots of benefits to a cooperative relationship with hospitals. Some, again, are related to a program like this, and some are in other ways.
Key components and next steps to creating a successful ICS arrangement. So give us the highlights, Dr. Valadie. What's needed, then what, and just give us the high-level points on what needs to be done to get things rolling.
The first thing you have to have is a relationship with the decision makers and someone that's willing to partner and willing to take some time and energy to look at this. You really need to have surgeons that are willing to change behavior, and it's really not effective if you have one or two surgeons that are driving this. You really need to have some contribution to the program across the board, even from surgeons that say just do the occasional hip fracture, but you really need everyone pulling in the same direction. Then yet, as with most things, you need to have a meaningful incentive structure. So the physicians need to have some direct tie between their behavior and their reward, so that they know that, hey, if I'm going to make some sort of change in my behavior, there's going to be a meaningful reward to me and to the group. Again, having high baseline costs help because it is a time-limited opportunity. And then we found that getting feedback on a consistent basis was very helpful because it keeps it front of mind.
So as I've talked about, a lot of the hospitals are not willing to talk about this opportunity, or they can't get to the right people. It's highlighted here that Fusion 5 and HCA Healthcare have a corporate agreement in place. So if you work with an HCA hospital and you're not able to open those doors or walk through them, or you're getting some pushback, there are some corporate folks who support this program, and possibly we can push that downstream to you. In your opinion, Dr. Valadie, was the HCA partnership with Fusion 5, was that beneficial to your negotiation at all? Did it help you out?
Absolutely. I mean, if anyone's ever negotiated with HCA before, it's not the easiest thing in the world, right? Their legal department is large and conservative and not exactly speedy. So really, you guys and Jerry really handled that entire process for us.
So some important things to consider and some words of wisdom from you. Be aware of the following. I know that you talked about that time-limited opportunity. So the baseline cost full reset. Would you recommend, obviously not going 2 feet into this, picking the measures that can drive savings, but not trying to achieve all that savings at once? Give it some longevity. Is that what you meant by a time-limited opportunity?
Well, I think, again, it's make hay while the sun shines, meaning that with baseline cost resetting, you can only drive them down so far. So our goal was to hit singles and doubles rather than home runs. I think if you go in and you go full speed ahead with a single vendor, low demand implant, I think that's great. But in a year or two, when prices reset, there's going to be no opportunity. I think you need to be aware of what the program costs, and you have to keep it front of mind. So you have to make sure that you cover your costs and you have enough left over for meaningful incentives for your surgeons. And as I mentioned before, you really need to have everyone pulling in the same direction. You can't have one or two surgeons driving the program because they'll get fatigued.
Yep.
From an advice standpoint, from an advice
Mm-hmm.
standpoint, I think you have to realize that, these aren't huge dollars, but something's better than nothing. And it's time limited. So pay attention and do well while you can. And hopefully you can get several years out of the program, and make sure that the hospital drives some benefit as well. And if they don't, they're not going to be motivated to continue it. And frankly, interestingly, sometimes if they do drive benefit, they're doing so many other things and busy with other issues that, they might not want to continue it. But I think having it mutually beneficial is an important thing.
That really concludes the presentation. Dr. Valadie, thank you so much for giving us your perspective on the program, how you set it up, and hopefully some other partners will find this extremely beneficial and can set up similar partnerships and achieve similar financial gain. So I appreciate your help, and thanks for joining us.
Happy to. Thank you.